Yesterday we had some technological issues, but that's how it is with technology. We can't live with it and we can't live without it, unfortunately. So I'm going to very quickly try to introduce Dr. Lance Stell. It's going to be quite difficult to do that because his CV is more than overwhelming. And it's really humbling to be able to listen to him and to learn from his expertise. So I'm going to go very briefly over his biosketch. So Dr. Lance is definitely is a PhD holder. He's a Samuel E. and Mary West Fracture Professor of Philosophy, Program Director in Medical Humanities at David Sims College. He is also Clinical Professor and Medical Ethicist at the Department of General Surgery, Carolinas Medical Center, and a Clinical Professor at the School of Medicine, UNC Chapel Hill. Professor Lance is a Professor of Medicine at Translational Science Institute. He graduated with cum laude from Hope College. Then he finished his master's at the University of Michigan, and then his PhD quite some time ago. He has a huge number of publications. He is quite well known in the circles of bioethics. I have had the honor, if I may say that, of virtually meeting Lance over the NCW listserv, and I have to admit that I learned a lot, and I'm still learning a lot from his posts and comments about very important bioethics issues that are appearing every day. Dr. Lance is also on several editorial advisory boards, such as the Physicians Index for Ethics in Medicine, and he is a manuscript reviewer of several journals, such as the Journal of Medicine and Philosophy, as well as major college committees, such as the President's Task Force on Strategic Planning, in addition to several medical ethics committees. He has over 100 publications in medical ethics, which range from books to articles, book chapters, public lectures, and TV shows. I do invite you to listen to some of his talks on YouTube. They are really enlightening and fascinating. And without further ado, thank you very much, Lance, for joining us today, and the floor is yours.
Thank you, Thalia. And Tala, thank you too for putting up with the difficulties we had yesterday, and Thalia for inviting me to do this. Let's see, is the PowerPoint available to see?
I will start sharing my screen. Okay. Can you see the PowerPoint?
Not yet.
Hmm. Mm-hmm.
So while we're getting that running, let me just say that you should feel free to interrupt me at any time with questions, comments that you have. You needn't save those to the end at all. So I welcome interruptions.
Thank you very much, Lance. Thank you very much.
My PowerPoint has a few. Oh, there it is. Okay.
There it is. Yes. Finally.
There it is. Yes. Let's see. Okay. That's the beginning. All right. Are you going to control its advancing or not? I guess you have to, because I don't know that I could do it.
Yes, if Tala is sharing, I think that she will have to. Whenever you give a sign, I think she will switch the slides.
Okay. So let's have the next slide, please. And already Greg said how much I appreciate this, the opportunity. And one large question that is recurrent in medical ethics, but in ethics generally, and that is how much value uniformity to impose in patient care or in society generally. There is a need for uniformity, but there's another competing concern, and that is how much individual discretionary privilege to recognize, how much individuality, how much difference to recognize. And a number of settings which this shows. Most recently, in thinking about our pandemic, societies have had to decide how to think about restrictions on the population. Should everybody be restricted, or should we focus on those who are most at risk? And we've gone all over the map on this. Some have used a lot of uniformity to try to impose, and that's difficult to do because people aren't that easy to control, for one thing, especially if they don't understand. And secondly, they disagree about how much liberty they want to give up and how much they should be able to decide for themselves how to respond to these challenges. In a more traditional sense, and more common one, are problems in medical ethics that arise over the uniform determination of death, for example. And in many societies, this is true in the United States, there is a statute called the Uniform Determination of Death statute, which allows for determining death by neurological criteria, as well as cardiopulmonary criteria. Well, we also know that there are some religious communities that do not accept neurological criteria for death, and they will have provisions that enable family members to veto the determination of death by neurological criteria. And this can have the unusual circumstance where in one jurisdiction, the patient is alive, and in another jurisdiction, the patient is dead. So there's obviously non-uniformity in respect to the determination of death. One particular problem I can tell you I had that surprised me, and that is a doctor asked whether he needed to get consent from the family to do a death exam, particularly since the patient was too unstable to do an apnea test, and he wanted to do a brain scan as an ancillary test to determine whether the patient had any perfusion of his brain. The family disagreed with the doctor and said that he did not have permission to transport the patient to have an image made. And so the doctor's question was, does his privilege as a doctor include the privilege to determine whether the patient is alive or dead? Now, there are arguments can be made on both sides of this. One argument is on the family side that if the patient can't decide, then next of kin get to decide, and that you can't do things to patients without consent, either from the patient or the family or someone else legally recognized. On the other side is the argument that doctors must make the distinction between those who are alive and those who are dead. And to treat them as if they were the same is a mistake and maybe a fraud. So those are just a couple of examples, and I'm sure you could think of examples too, where the uniformity versus individuality question arises. As I proceed through this talk, please keep in mind, there's one wonderful parable about three blind men and the elephant. Blind men felt different parts of the elephant and then gave different reports as to what the elephant was. The blind man who felt the leg thought the elephant was a tree. The blind man who felt the side of the elephant thought the elephant was a wall. And the man who felt the elephant's trunk thought the elephant was a snake. Now, in some ways, we all face challenges about what it is that we're seeing and feeling and hearing. And that's true in ethics consultation as well. I can also remind you of Plato's cave, where one person left the cave and was illuminated. And when he returned, the people would not believe what he said and were dismayed by what he said and even thought about killing him. Next slide, please. So let's define ethics committees so we know what we're talking about. This one comes from the Quinlan case, where ethics committees were first prominently mentioned, at least in the United States. And it defines an ethics committee as a multidisciplinary body composed of physicians, social workers, attorneys, and theologians, which serves to review the individual circumstances of ethical dilemmas. And this has provided assistance in the safeguard for patients and their caregivers, legal protection. The authority of these committees is restricted to the hospital setting, and their official status is more like an advisory body than an enforcing body. Next slide, please. So let's go ahead. This goes back a little bit. Okay, next slide. Next one. All right. This is, okay, we can go ahead too, and that is, this talks about what is ethics consultation in individual patient care, defining that. And again, you get some kind of a definition that this is a community exercise in which there is crowdsourcing of ethical expertise and knowledge to try to illuminate and see a way through a controversy, to resolve the ethical controversy. Now, this is a humor slide showing a gathering of individuals, maybe a community, where it showed that peaceable resolution of a conflict was not going to happen. One of them had a pistol and had shot somebody else. And so it said, well, not quite there with the resolution of conflict, are we? And so my question is, in your institution or anywhere else, who effectively holds the pistol when it comes to the resolution of disputes? Is it the legal department? Is it the hospital administration? Is it the doctor? Is it the surgeon? Is it the ethicist? Who is it that holds the pistol and can end the controversy? And that may vary from different settings. We'd have to say traditionally, doctor knows best, and the doctor makes the call. But we also know more recently that patients get to make the call, and patients may fire the doctor, may fire the hospital, may fire almost anybody, and so that they have command of what's going on. Next slide, please. Okay, this is the first case, and I call it, what is your authority? And that was the question that the surgeon posed to me. This patient is a 60-year-old Caucasian female who is a retired cotton mill worker about 20 miles away from Charlotte, with a 20-year history of worsening aortic insufficiency, probably related to her working in the cotton mills. So she was becoming increasingly short of breath. Her functional status was declining, and so she was referred for a cardiovascular surgery consult. The surgeon proposed a valve replacement, but the patient declined. It took several visits with the surgeon as she gradually got worse to finally come to trust him and agree to a valve replacement. In the process of doing this, she had executed a living will and a healthcare power of attorney. These are two documents that are available in all jurisdictions in the United States, but they vary in detail, and they allow a patient to direct the course of care when they lose capacity, and they also designate someone to talk on their behalf when they cannot. So we're on now 6 weeks after the valve replacement, and the patient remains on the ventilator and is now pretty much slow in her responses to any stimulation. She's not comatose, she's not unconscious, but very, very slow in her responses. The daughter requested an ethics consult, and she wanted to rely on her mother's living will, requesting that the vent be removed and that her mother be allowed to die a natural death. The surgeon refused. The ethics consultant, who in this case was me, visited this very ill-appearing patient at her bedside, where I met the daughter, her sister, and their nurses. And after getting their impression of what was going on and recounting what the patient wanted and what she was like, I went to see the surgeon to discuss the case. His first response was a challenge. What is your authority? Now, I have to say that I had not really thought very much about what authority that I had. And he wanted to know if the credentials committee of the hospital had reviewed my credentials and had decided to give me a delineation of privileges, which would include the privilege to interview family members and receive confidential information, the privilege to access the patient's medical record and to read it, to talk to various people who were related to the patient about what they knew about the patient and so on. And then ultimately, did I have a privilege to offer my impressions and recommendations to be entered into the patient's progress notes? And those were many questions that I had not really thought about in great detail. And this, to this day, is somewhat elided amongst ethics committees as to whether there is a delineation of privileges for the ethics consultant or the committee. What if it's a committee that is empowered by the medical staff, then those would be ordinarily outlined there. If it's an administrative committee, then those would be outlined in an administrative manual of some sort. Next slide, please. So after talking to the surgeon and being put on the spot, we agreed to go back to the bedside because he asked me whether I had seen the patient that day. And I said I had been at the bedside a few hours earlier. He said, well, let's go back there. So we went back to the bedside, and amazingly to me, the patient looked completely different. She was smiling. She smiled at the surgeon when we came in the room. She frowned at me. She clearly was interactive and aware. The surgeon reviewed the patient's course in her hospital, her healthcare course, and he did that for my benefit because he wanted to demonstrate the patient's understanding of the circumstances. Then, after all that, the surgeon point blank asked the patient, Betty Sue, I think I can get you a vent, but maybe not. Do you want me to continue the ventilator? The patient promptly nodded in the affirmative. Next slide, please. So, where are we? I mean, what to do at this point? It seems that the patient has given permission to continue with the course of care that the surgeon has proposed, and there's really no role whatsoever for anyone to play in this case. It's a doctor-patient issue. The doctor offers treatment. The patient accepts treatment. Case over. Well, not so fast. Not so fast. Because when we left this bedside conference, we adjourned to the surgeon's office, and the patient's daughter became very distraught. And she told the story that She had been caring for her mother's increasing disability for some time, and it had cost her a lot financially and emotionally. And now her daughter had become diabetic, and caring for both of them at the same time was financially burdensome and also emotionally burdensome. And she had hoped to inherit the mother's house upon the mother's death. And now it looked like she would not be able to do that because the bills for her mother's care had mounted to the point where inheriting that house was questionable. Well, that disclosure, that confession was dramatic and shocking, I have to say. And the surgeon was appalled, quite frankly, that the patient would, or the patient's daughter would use those possible considerations in making a healthcare decision. And so he turned to the patient's daughter and said, "May I give you some advice? I want you to butt out." That was blunt, it was harsh, and an amazing thing to say in the circumstances. The follow-up situation was that the surgeon then proceeded to fire the pulmonologist who had consulted at that point, hired a new pulmonologist who weaned the patient, and she was discharged from the hospital on a walker after 30 days. Next case, advanced care failure or iatrogenic guilt. And as I said before, please do feel free to interrupt me, ask me questions about these cases, or anything, any question or thought that arises to you. I'd be glad to try to respond. The next case, the patient is a 60-year-old white male. Interesting question right there. What's the point of designating the race of the patient? Is that a legitimate thing to do in a case report, or is it not? And increasingly, the use of racial demographics in patient reports has gotten to be a problematic thing in the hospital, and I think in healthcare generally, as to whether it's ever relevant or it's particularly relevant sometimes. Perhaps it might help you illuminate why it is the patient is distrustful of the hospital or other things. So the racial demographic is a problem, is controversial. So this patient was admitted for a carotid endarterectomy, second to bilateral carotid artery disease and diabetic vascular disease. And all of these vascular problems really stem from his diabetes, which was very brittle. It was difficult for him to control his diabetes. His blood sugars would go very low, they would go very high. And the patient was at that point having increasing numbers of transient ischemic attacks. That is, he was having brief fainting spells, and he could faint anywhere at any time. The patient had been an employee at the hospital, and it turned out, as this case developed, that many of the hospital workers knew him. But initially, that was not appreciated. So the endarterectomy was performed. The patient was subsequently taken back to the operating room for additional interventions. He had a hemicolectomy secondary to a bleeding cecum, a right colonic arterial venous malformation, a splenectomy, second to a splenic vein thrombosis, and a cholecystectomy, secondary to gallstones. His postoperative course was complicated by recurrent bouts of sepsis, peritonitis requiring re-exploration, during which a gastric perforation was found and repaired, and further complications included his wound had fallen apart, probably because he was not really well perfusing his tissues for healing. He was a prolonged ventilator dependence. He had ventilator-associated pneumonia, ARDS, and progressive nutritional deficiency requiring parenteral and enteral hyperalimentation. Next slide, please. Initially, the patient seemed to be improved, but over a period now of nearly 6 months, he has been unable to achieve independence from the ventilator and artificial nutrition. The patient's decisional capacity, always a crucial issue in any circumstance of patient care, was up and down, in and out, waxed and waned as he was septic, and then the sepsis would clear. The patient had previously exercised advanced directives. He had exercised the North Carolina Declaration for Natural Death and the healthcare power of attorney, naming his brother as the attorney or his representative. Conflict developed between the surgeon and the pulmonologist over whether the patient could be weaned. The surgeon thought the patient could be weaned. The pulmonologist was doubtful. Additionally, the nurses believed the patient was being overtreated and that his wishes were not being respected. So they requested help from the nursing administration department. However, the nursing administration department referred the thing to the ethics committee. In the process of trying to deal with this, the patient was, when he was lucid and awake, would try to speak to people in the room, but you couldn't really tell what he was trying to say because he was tricked, and it was puzzling as to what he was saying. So it turned out that one of the nurses, the fiance of one of the nurses, was a lip reader, and she offered his services at the bedside to assist in the interpretation of the patient's attempt to communicate. So a bedside conference was arranged, and it was a roomful. There were physicians, surgeons, nurses, social worker, neighbor, priest, the ethics committee consultant, and the lip reader. A full room for sure. But the result was non-contributory, to put it the least. The lip reader struggled to try to translate mostly failed, and immediately communicated and indicated frustration at trying to interpret what the patient was saying. When the surgeon asked the patient whether he wanted to continue with the ventilator and feeding tube, the patient nodded. When his brother at the bedside asked whether he wanted him to continue as the representative in decision-making, the patient also nodded. In fact, the patient nodded to everything that was asked of him. Next slide, please. So now we run into a general kind of question. Do doctors and hospitals have an over-treatment bias? Is there a tendency for doctors and hospitals to push too hard on treatments and not recognize that it's appropriate sometimes to stop? Now, there are two popular reactions to this question. Next slide, please. The first is this, I love this slide. A gentleman appearing before St. Peter as he's going to enter heaven. And he says to St. Peter, "Sorry, I'm late, but they had me on life support for 2 months." And this suggests the circumstance where everyone had appointed time to die and appointed time to live, and they should not extend past those boundaries, that you should live as long as God wants you to live and no longer. But humans, doctors and hospitals, can interfere with that and make a patient show up late. Next slide, please. Here's another image of the same circumstance, but now something different. These are two gentlemen in an ICU, both of them hooked up to tubes and machines of various kinds. On the bedside between them, there is a newspaper which says, "Most favor pulling the plug on those who are hopelessly ill," a study. One gentleman says to the other, "I'm going to take a nap. Watch my plugs, will you?" Now that suggests that there's concern among some patients about being ushered too quickly out of this world by doctors and hospitals who can not get you dead quick enough. Next slide, please. Case 3. This is the plaint by the the nurse that was taking care of this patient. How can I take care of a patient I cannot touch? The baby's cares are self-defeating, inhumane, and futile. Come to the bedside immediately. That was the way she talked to me on the phone. This case involved epidermolysis bullosa of the Halipo-Siemens variety. It's a case that turned out to be one of futile treatment. Next slide, please. The baby is a male, born at 28 weeks gestation. Epidermolysis was apparent at the child's birth. More than 50% of the child's epidermis and left ear had rubbed off in utero. Medical problems included respiratory failure and renal insufficiency. A dermatological consult was obtained, and the dermatologist diagnosed junctional epidermolysis bullosa, Halipo-Siemens type. Prognosis, untreatable, uniformly fatal. The biopsy was sent to an internationally recognized epidermolysis bullosa expert for confirmation at the request of the family. The family was offered additional consultation and they took it. So the biopsy was sent out of house to him as an expert. The social history involving this patient was interesting because of consanguinity of the parents. They were cousins. The mom was 20 years old. The dad was 41 years old. And the parents received instruction about the genetic risks that were involved in this disease. And the mom, after hearing all this, said, I can't risk another pregnancy. This is the only baby I will ever have. Both of them opposed withdrawal of support. They rejected a palliative medicine consult to ease the distress of their child. The couple had a pastoral advice, that is, they had a minister who was supporting them at the hospital, and he opined that life and death are in God's hands and the doctor should not play God. Next slide, please. This will show you how dramatic was the presentation to see. Very dramatic indeed. So you can see the vasculature in that baby very, very clearly, showing how much of the skin had come off. So with the biopsy sent out to the outside expert, he was out of the country. And the biopsy was read erroneously by a fellow whose opinion was that the condition was homozygous dominant and it was a non-lethal form of epidermolysis bullosa. The original consulting dermatologist was dismayed at this and said, this is obviously an erroneous read of the biopsy. Nevertheless, the discordant opinion was conveyed to the parents, from which they thought there was reason and miracles. The expert returned from the conference out of the country, reviewed the biopsy, and confirmed the original epidermolysis bullosa and the yes, the consult by the original consulting dermatologist. Parents. The parents were obviously in disagreement with the suggestion that they stop, and they seized on the fact that the doctors disagreed. Doctors don't know everything. They must not play God. Miracles are possible, and a 24-hour bedside prayer vigil was arranged. Now, this was very short duration. That is, the prayer vigil only lasted through one evening, And then I'm not sure exactly why, but everyone then departed the bedside. And from that point on, the mother would not return to the bedside to see her baby. And this additionally caused upset to the nurses who felt that the mother had to be involved in the decisions about the baby's care and she wouldn't come to the bedside. So now there's a little interlude here about moral distress in nurses in a study that looked at moral distress in the nursing community. And the study found high levels of moral distress frequency when nurses deemed that the care being provided was futile. The highest levels of moral distress frequently occurred when the wishes of the patient's family were followed, even though the nurse believed that doing so was not in the best interest of the patient. Next slide, please. So moral distress is psychological distress of being in a situation in which one is constrained from acting on what one knows to be right. Next slide, please. So now the question, can futility be objectively defined, or is it necessarily infused with value judgments in which the doctors are not expert? Now, there clearly are cases where futility is objectively definable and where treatment will be futile. Here's some examples. Trying to treat a viral infection with antibiotics is futile. Trying to cure erection dysfunction with a goat testicle transplant, as was popular in the United States in the early part of the 20th century, is futile. Curing female schizophrenia, hysteria as it was diagnosed, by a hysterectomy is futile. Curing fever with phlebotomy is futile. And that's a medical treatment that was not discontinued until the mid-19th century. It was actually recommended by Dr. William Osler during the 1918 flu epidemic when there was nothing else to try. And ligating the internal mammary artery for angina, also futile. So there are a whole bunch of things which have proved to be futile and were in fact used sometimes. So that can be objectively ascertained. They cannot cause an end to the distress or cure the condition. Then there are normative interpretations of futile, which simply means that the intervention may be effective, but it's not worthwhile because the goals of medicine are not being promoted. Next slide, please. Now, when something is medically futile, there's no duty or obligation to continue the intervention unless it promotes a valid goal of medicine. Well, what is a valid goal of medicine? Well, this has been a lot discussed, obviously, since the time of the ancient Greeks forward. And for Plato, for example, discussing the Asclepians who were Hippocrates was an Asclepian, a member of the school of Asclepius, were noted for not offering treatment to people who were overmastered by their diseases, and that the arts of medicine were not to be used in those cases. It was an abuse of the art. But the question is, it'd be wrong to do, but is it unprofessional to do? And some people think, yes, it is unprofessional and doctors should not do it once they make this determination that the goals of medicine cannot be pursued. Others say, wait a minute, there is a utility, a symbolic utility, even if there's medical futility, and that some people might feel nobility and dignity in struggling against the inevitable. And we think about various ways in which futility is depicted in various myths. For example, the myth of Sisyphus, is that a noble pursuit of Sisyphus as he pushes the stone up the mountain only to have it roll back down? Or not? Is there any nobility in that? Some people think maybe there is nobility in that, to resist what cannot be resisted, and that is the stone is going to roll back down. So these are all continuing background concerns about how people may think about futility. Next slide, please. So this just gives a brief summary of some of the stuff in the medical literature about futility. And what this shows is a gradual emergence towards recognition that doctors don't have to do everything, that there are circumstances where a doctor can stop, even if there is insistence on it by the patient or the patient's family. And these positions have been actually incorporated in statutes in various jurisdictions in the United States. Next slide, please. I think philosophically we can say that in medicine, you cannot dispense with the concept of usefulness or efficacy. Actually, medications and surgery must be efficacious if it's to be beneficial, right? So if efficacy is an essential medical concept, its complement, futility, inefficacy, is a logical complement of that. And it can't be banned as somehow inappropriate language or stuff that we can't say. If it's either futility will operate out in the open and be regulated by fair procedures, or it will operate surreptitiously, unregulated, and dishonestly. So generally, I think personally, and I've tried to urge this in a number of settings, honest requires procedural fair policy to honestly deal with controversy over futility. Next slide, please. But who wants to test these ideas in court? Now, this is another humorous slide showing trial lawyers looking like intimidating, trying to intimidate people who want to take malpractice cases against doctors who rely on futility. Next slide, please. So when we think now about the case of the baby with epidermolysis bullosa, what happened? Well, what happened was that there was multiple meetings with the ethics committee, and it was decided that the doctors did not have a duty to continue to treat the baby and trying to preserve it, because death was inevitable. It was only a question of how much distress would be inflicted, and it would not be wrong for the doctors to discontinue treatment. The nurses agreed with that, but they wanted the mother to participate and be present when the baby died, and they prevailed on the mother to come to the bedside and hold her child as treatment was withdrawn and enough morphine was given so that distress was not overwhelming, and the baby passed away. There's follow-up on this case too, because 18 months later, this same couple showed up with another epidermolysis bullosa case that looked like the first one. And that case did not last but 24 hours because there was not any willingness to inflict distress on the baby for as long as the first one was. So I leave with a little bit of humor here, showing an ethicist in hell. There must be some mistake. I was on the ethics committee for 22 years. So I'm glad to hear any questions that you have or comments that you have about these cases or related things.
Thank you very much, Lance. That was very interesting. I'm going to abuse, if I may, my role as host and ask two quick questions and then leave the floor to my colleagues. The first one has to do with living will. Now, in Lebanon, living will and POAs are not, do not work. We don't have them by law because they might be a slippery slope to euthanasia, which is totally forbidden by in Lebanon, because we usually take the approval of the clergy for any law that is related to such issues. Now, my question is, the issue of making a decision, assuming the living will is there, is sort of nebulous, because it seems to me that autonomy in this case is a spectrum. So from the time I write my living will to perhaps the time the patient goes into a certain medical condition that perhaps changes his views on things, and his identity also changes on that spectrum. So how valid would that living will actually be? That's the first question. And the second one, very quickly, can we or should we actually dissociate qualitative and quantitative futility? And if yes, according to who? It seems to me that they are intermingled together, and we can't vote through one instead of the other. I really would like your input, and just to know that we had very similar cases, and it was very interesting to see how you dealt with them as well. Thank you, Lance.
Okay. Well, the first one about advanced directives and whether patients we know that patients do in many cases accommodate the disability. And that when one is in one state of health, thinking about a future state of poor health, would think that that's intolerable, and one would never want to survive in that kind of condition. And then, of course, over time, as disability progresses, they learn that survival is fine under those conditions, and they don't want necessarily to be rushing out of this life. So the cartoon showing two elderly men in the ICU reflects that kind of concern. These are individuals who are not eager to get dead, and want to be guarded from those who are too eager to get them dead. And that is the problem, is to the continuing and ongoing validity of a document that may have been drafted under very different circumstances. And should next of kin or somebody be in a position to overrule what's been said in the advance directive? And yes, I think they should, but then who's going to get to do it on what basis? When we go back to the case of Betty Sue, the first case where the surgeon would not stop, and then it was revealed that the next of kin may not have been, well motivated. What should have been done in that case? Should we have asked the hospital attorney to disqualify the daughter as agent for the patient because she had shown herself to have conflicting motives? We thought about that, but we didn't do that. And I think part of it was an awareness that no court would have disqualified her. It's very, very difficult to disqualify a chosen individual for a patient that a patient is chosen for himself. And it does happen, and we've had it happen. But you raise a very, very difficult problem, and we struggle with it. It's that's all I can tell you. Now, the second question you asked was about futility. Is that right?
Yes, you raised the issue of quantitative versus qualitative.
Oh, yes. I think that distinction is hard to sustain. I think that the futility does import the notion of what's worthwhile. And you can't really separate in medicine what's efficacious from what's worthwhile. So to say that something is totally effective but not worthwhile doesn't make sense, I think, in many circumstances. Could you think of an example? I think maybe you could. But yeah, I mean, that's a problematic case. And anytime, is it futile, for example, to treat someone who has been diagnosed dead? Well, you would think you shouldn't treat the dead as if they're alive, right? Well, what if the person is a possible candidate for organ donation? And there's a statute that says, as there is in North Carolina, that says that if someone is a candidate for organ transplantation, interventions may not be withdrawn until their status is clarified. So that would mean that even though they might be diagnosed dead by neurological criteria, removal of interventions would be prohibited by state law until the disposition of their status as an organ donor has been clarified. So it might be that a continuation of the event would be required. They might get factor VII, various antiplatelet therapies that would control bleeding. All kinds of things could be done treating a dead person. And you know, on the other hand, you say, well, how can you justify treating the dead as if they're alive? Well, that's a problem. That's a problem, and we've had that problem.
Thank you, Lance. Of course, that opens another can of worms when we speak about worthwhile. Is it worthwhile to whom? To the patient, to the family, or to the physician? But I'm going to respect the time and leave my colleagues. I'm sure they have a lot of questions. Some of them are already in the chat. So the floor is to my colleagues for any questions. Tyler, if you can monitor, please, the chat box.
Yes, sure. We have questions here. Someone, Amar Shaibata, wanted to comment on case 2. She's still with us.
Yes, my name is Amr Shbeita. My name is Amr Shbeita, and I'm from Egypt, from the National Research Center. And my question is, how will you balance the medical oath for physicians and doctors and nurses and caregivers, medical caregivers, do no harm, with who will take the decision to withdraw the patient from life support, whatever it is, ventilator or whatever intervention is. How will you manage that?
Yes, exactly. So when we think about, say, the case, the epidermolysis bullosa case, where the baby does not have a survival future, is a question of how much distress will be inflicted on that baby as it dies. In this case, as you may remember from the pictures, the ET tube was initially taped to the baby's lips, but that had to be stopped because that tore the tissues off of the baby's lips, and the ET tube then had to be sutured in place. And as the nurse said, she could not care for the baby because she couldn't touch it. Every time she touched the baby, skin would slough off, and the baby would recoil in pain. We had anesthesiology come by to make any recommendations for pain management, but the baby was so small that they couldn't really make any kind of reliable recommendations for pain management. So in that particular case, the inability of the nurse to actually touch the baby, which she needed to do to provide its cares, was ruled out. So that was obviously very distressful. I recently had an email back and forth with a consulting dermatologist who said she will never, ever, ever forget this case. And I think none of the persons who were involved in the case would ever forget it either, because of the intensity of the circumstances and the difficulty of telling a parent that we're going to stop and we want you to hold your baby when we stop. And that looked like, well, it was very difficult and very, that's all I can tell you. It was very difficult.
Yeah, thank you. But what about the medical staff, the caregivers? Did anybody know what are their feelings, how their emotions, how will they cope with this case in their future?
Yes.
Because we are humans.
Yeah. Well, we did have the irony of an exact repeat of the case. At the time when we had the first one, we thought, well, this will never happen again. But lo and behold, 18 months later, it did happen. And that time, in the second go around, they had prenatal diagnosis of the pregnancy, and the condition was diagnosed prenatally. So that the parents knew that their baby that they were carrying was going to be another EB baby. They knew it. They were opposed to abortion.
Okay.
They would not even think of abortion. So this child was born, and lo and behold, he had sloughed off almost all of his skin, and it was looked like exactly like the first one. So what to do about this? I mean, we couldn't believe it that we had another one just like this. It was known in advance. So that's one difference. The first birth, it was not known in advance, and it was handled in such a way that the doctors and the nurses and the hospital were all of agreement that this was not going to be drawn out for weeks at all, and so it wasn't.
Thank you very much. Thank you very much. It was an amazing, informative session for me as a dentist and as an ethicist also. Thank you very much.
You're welcome.
Thank you. We have Dr. Hazar Haidar. She has her hand raised. Go ahead, Dr. Hazar.
Thank you, Professor Lenz, for this very interesting presentation. So my question is particularly about the third case. While it's very clear who might be the decision makers for the first two cases, but for the third one, it's sometimes difficult to know who are the decision makers on behalf of the baby, because it's clear it's a baby. So is it the healthcare professional who's taking care of this case, or the parents? And are there any policies or legal frameworks that are like there to help out the professionals in order to take the decision on behalf of the parents if, for instance, it is clear that there are no, treatment or other alternatives?
Yes. We have had cases where advocates for the disabled have participated in and intervened in attempts to wrest control from a family member in the hospital. One particular case even made the national news in the United States, where a mother had decided to discontinue treatment on her cerebral palsy child, and advocates for the disabled went to court and sued for custody of the baby away from the mother. And they succeeded in that initially. That decision to take away from the mother the custody of her daughter was appealed to a higher level court, and the court restored custody to the mother. It was a terrible case because the advocates for the disabled wrote an editorial in the local paper attacking the mother as being badly motivated and participating in the culture of death and on and on. And I can tell you that was grossly unfair to the mother of the child, of the girl, grossly unfair. And she had demonstrated for years bonding care for that girl no matter what. And to have her character assassinated in the local press was unconscionable, in my opinion. And the mother even asked me to write an answering editorial to these advocates, which I did. And but yes, sometimes it does. It can spill into a court. There can be contests over custody. Those things. I mean, when we think about this, what happens when for one thing, the clock continues to tick, and there are costs and distress that are inflicted on people as the time runs, and it can be the legal process does not move swiftly very often. And so enormous harm can be inflicted on people as things wind out in the court. So, yeah, the answer to your question is these things do have additional dimensions of process, but they have their costs and sometimes very distressing ones.
Thank you. We have Mrs. Wadad Al-Hus. She has her hand raised as well.
Yes. There is a debate on Medscape and social media concerning requiring pharma companies to deny meds to the Russian people as part of sanctions against Russia to put pressure, of course, on the political leadership in response to the Russian-Ukrainian conflict. This is somewhat similar to denying treatment or interventions to patients against their wishes. As ethicists, what would your opinion be about that?
Oh my. Well,
Wow.
yeah, I mean, the thing is that I guess there's almost no way to keep keep some questions out of a bioethicist's backyard. I am a political philosopher as well as a bioethicist, but you know, when we think about the behavior, the way I see it, and I guess I'll just tell you my personal view, and that is that, you know, a horrible injustice has been inflicted on the people of Ukraine by the invasion of their country by Russia. And whatever provocations Russia may think that have been that justify their doing that is I just don't see it at all. And but it's also very complicated, as I'm sure you will agree, that trying to see any peaceful way out of this, I don't see it. I mean, I think on the political side, it's getting worse and may get much worse because of the collateral damage that will be done to the world's economy, the availability of food in parts of the world that cannot stand any food stress whatsoever. And then when we think about medical care and all of that, it stands to be a horrible tragedy as well as an injustice. So I'm not really sure what the Russians are doing with respect to the care you're concerned about it. I just don't know. So I can't really offer any really intelligent commentary to you, I'm afraid.
Okay, thank you, and sorry for the question if it's a bit embarrassing.
Oh, I don't mind. You can ask me anything.
Thank you, Doctor. We have Dr. Muhammad Shuaib Ahmadani. He had his hand raised as well.
Yeah, thank you. Thank you, Dr. Lance, for this excellent presentation. It has opened our brain and given different scenarios. My question is just concentrating on the conflict management. In these scenarios, the decision making was with different people. There are 3, 4, or 5 types of stakeholders involved: surgeons, nurses, patients, parents, priests, and ethical committee. So, what weightage we should give to the medical ethics committee or ethical consultant? The decision making or the conflict management? Keeping in view only the conflict management. That's my question. Thank you so.
Now, I'm not sure that I got that. So if I did get it, so the question has to do with the status of an ethics committee in a medical center and how their activities are to be accountable to somebody. Accountability is a major concern in ethics committees, I think, for sure. And whether a committee whether some of these cases that I mentioned to you should rest with the committee as a whole, as opposed to an individual ethics consultant, is an ongoing question. And I may be just going way off from what you really wanted me to address. I feel like I might be, but I can say, well, I don't understand that question, but I'm going to talk about another question.
That's sorry, I explain in a different way. The bullet points, how much points will give to the access committee for resolution of the conflict?
Oh, yes. Well, ethics committees can certainly make things worse. It's certainly possible. And when we think about the ethics of ethics committees, they should not make things worse, but should they be thinking of themselves as primarily in one corner or another? Because some people think that the ethics committee should be an advocate for patients. And sometimes they are, but sometimes they're an advocate for nurses or for doctors, because the idea, at least this is my opinion about the matter, that ethics committees ought to be on the side of right as they best can see it. And sometimes right and good lodges with the doctors and not the family. And the family is unreasonable, and they've made demands that should not be accommodated. And although in other cases, it seems that the doctors are out of line, that they have arrogated to themselves more authority than anyone should have, and need to be reminded that they are servants of the ill and are not dictators. But
so, Lance, if I may add, there are cases where members of the medical ethics committees have been sued. And,
yes.
And there's a distinction, I think, in this region, it's not very well known, between the members of the medical ethics committee and the role of a medical ethics committee per se, as opposed or different from the bedside ethics clinical consultant, as such as yourself. Just between brackets. Thank you.
Yes, indeed. Well, in the case of, in the one case that I mentioned, where there was, I suspected iatrogenic guilt on the part of the surgeon. As it emerged, the surgeon had known the patient for quite some time, because the patient was an employee of the hospital before he became disabled. And the patient, as his vascular condition worsened, was having increasing fainting spells. He lived alone. He refused to move to another city to be close to his brother, which was offered many times. And so the surgeon had told him that, you know, he was at risk for falling at home, hitting his head and dying on his kitchen floor all alone. And it was on the basis of an entreaty like that, that the patient finally agreed, even though he suspected that were the surgeon to do the surgery, the endarterectomy, he would wind up on a vent and not be able to get off. And that's exactly what happened. Now, the surgeon, I think, wound up feeling very guilty about the fact that he had not made the patient better. He made the patient worse. And because he made the patient worse, he continued to try to get him back to baseline, which he failed to do. Every time the patient was touched, he got worse. He got more problems, more complications of everything. And I think that that was one of the reasons why the surgeon wouldn't quit. Now, the conflict escalated even further because the brother, who had authority, legal authority to speak on behalf of the patient, would not have his authority triggered unless the surgeon said the patient was incompetent and unable to decide. And the surgeon had not documented that. He had not. And the patient was in and out. Sometimes when he was septic, he was completely out of it. Other times when he recovered from that, he was interactive. So he was up and down, and the surgeon said, well, I can't say this guy's mental loss or incapacity is permanent, so I'm not going to document that he's lost capacity permanently. Well, that looked like a strategic move on the part of the surgeon to maintain control. So the surgeon is arguing with the pulmonologist about this. The brother says, I want to fire the surgeon and retain the pulmonologist. The pulmonologist said, I want to withdraw from the case. So what to do? Well, this was a case where I thought transfer of care to a doctor was the way to try to deal with it, and that's what happened. So I recruited a willing doctor from the medical staff who was highly respected in the hospital to assume responsibility for the case. And then the previous surgeon and the pulmonologist withdrew, and this new doctor took over supervision of the case in consultation with the brother. And then everybody backed off and let that thing run under the supervision of the brother and the new doctor.
Wow. And there's healthcare mediation as well. So Dr. Lance, I want to really thank you and be respectful of your time. I can see a lot of thank you note for a very interesting presentation, and I definitely concur that. Bless you, and we will keep in touch. Thank you very much, really, from the bottom of our heart.
Well, thank you for having me. I really, really appreciate the opportunity.
Thank you, Lance. Bye-bye.
Thank you so much, Doctor. Goodbye.
My pleasure.